Patient presented in the hospital is a 28-week pregnant woman, Michelle, with a history of gestational hypertension. She was tested for symptoms of preeclampsia, and the results are positive. Let us identify what is the difference between gestational hypertension and preeclampsia. Gestational hypertension is a high blood pressure without protein in the urine or other organ damage during pregnancy. A percentage of women, 10 to 25%, with gestational hypertension can progress to having preeclampsia. On the other hand, preeclampsia is a condition in pregnancy in which the mother develops sudden high blood pressure and releases protein in the urine. There can also be dysfunction of the kidneys, liver, or brain. It can happen after 20 weeks of pregnancy and also right after birth. About 4 to 5% of pregnancies are complicated by preeclampsia. What could be the symptoms of gestational hypertension and preeclampsia presented by Michelle? Her blood pressure is high or higher than 140/90, new light sensitivity, severe headache that doesn't get better, confusion, shortness of breath, new swelling of the legs, pain in the upper right stomach, and blood tests and urine tests show positive protein.
As nurses, we have prepared 3 nursing diagnoses and interventions for the patient. Let's start with our priority diagnosis. Decreased cardiac output related to increased systemic vascular resistance secondary to preeclampsia as evidenced by increased blood pressure, shortness of breath, edema of the palms, tachycardia, decreased urine output, and altered level of consciousness. The goal for the patient would be patient will demonstrate normal cardiac output as evidenced by absence of dyspnea and normotensive status by the end of the shift. In addition, Michelle will remain a normotensive and normal breathing pattern with reduced edema of the body, adhering to the treatment regimen for the rest of her pregnancy period for our long-term goal. For the interventions, first we have to monitor and document blood pressure and pulse every hourly or as needed. This is because hypertension results from biochemical changes that cause vasoconstriction and vasospasm. A short increase in blood pressure indicates progression of preeclampsia. Next would be measure urine output and proteinuria as per protocol.
We are aware that elevated levels of protein in urine decreases urine output and indicates kidney injury and impending eclampsia. Monitoring of intake and output is another intervention for patients with gestational hypertension due to hypovolemia and oliguria, such as renal hypoperfusion. A patient with preeclampsia and hypertension also requires strict bed rest in lateral position. Lateral position improves cardiac output by promoting venous return.
We also need to monitor electrolyte status and instruct the patient to reduce high sodium foods. Increased levels of sodium increase water retention, thereby worsening the edema. Administer antihypertensive medication as prescribed such as hydralazine, labetalol hydrochloride, or methyl-dopa. The rationale for this would be antihypertensive lower BP by vasodilation and reducing systemic vascular resistance. Lastly, prepare the patient and family for cesarean delivery if indicated due to the progression of preeclampsia or determined by the healthcare provider. Fetal and placental delivery ceases the progression of preeclampsia. Failed induction and/or attempt for vaginal delivery will lead to cesarean section. For second priority nursing diagnosis, ineffective tissue perfusion related to preeclampsia secondary to arteriolar vasospasms. With this, we aim for Michelle to exhibit signs of adequate tissue perfusion, such as adequate urine output and normal fetal heart rate tracing. To achieve this, following interventions will be executed. Administration of IV magnesium sulfate as per physician's order. Magnesium sulfate is used to relax vasospasms and increase renal perfusion. The nurse will place or encourage the patient to position in side-lying position. This will maximize uteroplacental blood flow, reduce blood pressure, and promote diuresis. We will also monitor fetal heart rate, baseline variability, and presence of late decelerations. This will provide us data if the patient still has adequate uteroplacental oxygenation.
For our final nursing diagnosis, we have risk for injury to woman and fetus related to CNS irritability or seizures. Our goal is for Michelle to show diminished signs of CNS irritability and have no seizure activity. For the interventions, we need to provide baseline data. This baseline data is used as basis for evaluating effectiveness of treatment. Magnesium sulfate can also be administered as per physician's order. Magnesium sulfate can decrease hyperreflexia and minimize risk of seizure activity. Continuously monitor maternal vital signs, level of consciousness, fetal heart rate, urine output, DTRs, and IV flow rate. This is to assess for and prevent magnesium sulfate toxicity. Have calcium gluconate or calcium chloride readily available in the unit as an antidote for unwanted magnesium sulfate toxicity. Lastly, maintain a quiet, darkened environment. This type of environment avoids stimuli that may precipitate seizure activity.